How do we achieve value? Though it's not easy, hospitals and physician leaders are focused on providing better patient-centered care and investing in alternative payment models to achieve value. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. In this podcast, Priya Bathija, Vice President of the Value Initiative at AHA, and Dr. Bob Pendleton, Chief Medical Quality Officer with University of Utah Health, discuss the importance of value in today's times and ways providers can remove barriers and build a sustainable culture of value.
Thanks, Tom. Today, I am here with Dr. Robert Pendleton, who is the Chief Medical and Quality Officer, a practicing hospitalist, and professor at the University of Utah Health. We're going to be talking a little bit about restoring the purpose of value and a conversation that he had with AHA members at an executive forum for the Value Initiative last year in September. Bob, thank you so much for being with us today. I'm excited to have this conversation and to really be able to share some of the thoughts you highlighted in Denver with our broader AHA membership.
It's my pleasure. Thanks for having me, and it's really an honor to be a small part of the Value Initiative that AHA is leading. Well,
let's start with kind of a loaded question, but why is value important?
That is a loaded question. I think, in my opinion, we talk a lot about sort of the macro level argument of a need for value in healthcare in the United States. And, we talk about things like 18% of the U.S. GDP is spent on healthcare. And we talk about things like life expectancy in the United States has been declining for the first time in over a half century. And those macro level sort of arguments, I think, are important, but they're also not the most compelling because healthcare isn't about macroeconomics. It's about the vulnerability of individuals, ourselves, our family members, our neighbors. And through that lens, a much more sort of personalized and individual one, value means something a little bit different. It doesn't mean macro level economics. It means the financial toxicity of everyday Americans trying to have to make choices between paying for health care or paying for things like food or college tuition for their kids or other things. It means that we're, as American citizens, not healthy enough to live our very best lives. And more, we're having to spend way too much of our own personal time managing our health. So health is at the forefront instead of it really being in the background. So for me, it's important not for those high level things, but really on a much more personal basis.
Yeah, and I think that makes sense. And when we've talked in the past, You've talked about how a lot of the field equates value with alternative payment models. So we hear a lot of hospital leaders think that value equals participating in an accountable care organization, being part of a bundled payment or a medical home. But how important are those types of things to achieving value when we look at value in the framework you just set forth?
Yeah, it's a good question and one that I struggle with, often in my own mind. And it's true that, I think value has really become a buzzword in healthcare, and it's tended to be conflated with things like payment reform and performance metrics and alternative payment models. But if we think about sort of the higher level aspiration of what our neighbors need of us in healthcare, alternative payment models are necessary, but not at all sufficient. And there is an awful lot that we can do to really drive value for individuals that entrust us to care for them, even in a fee-for-service environment. And I often remind people that, at University of Utah, where I have the privilege of practicing, we've been really pushing on making care easier for our patients, reducing the cost of care, improving outcomes for over a decade now, in the setting of an almost entirely fee-for-service market. So alternative payment models ultimately to get where we need to go are going to be necessary, but I do think it's important for everyone to recognize that they are completely insufficient, and there's a lot of work for us to do before payment reform happens.
Right.
And so, it shouldn't be an excuse. We roll up our sleeves and need to kind of get to work.
Right. So as you get to work, there are obviously a lot of individuals who are vested in this value conversation and want to improve health for individuals and communities. We have hospital leaders, we have physician leaders. How can everyone come together to really create a culture that supports moving towards value?
Yeah, I think, for me, I do believe that culture is everything. I mean, culture is the outward behaviors that reflect sort of our core values and beliefs. And when I think about culture in that way, it really does start with a clarity of purpose. And I think when you do work in a complex environment like healthcare, when you do work in a setting where, it often feels like there aren't enough money or resources to do all the things that you want to do, it's really easy to sort of fall into the trap of focusing a lot more on margin and productivity, and sort of losing sight of purpose. And so for me, I think hospital and physician leaders, it really starts with an honest look in the mirror and saying, are the conversations that I'm leading and having day in and day out really reflective of the purpose that I believe in? And once you're clear on your purpose and you're aligned on your purpose as an organization, the rest becomes a lot easier, because then it's just getting the right tools, things like data and dashboards to help you learn and get better, putting in the right systems like reward and recognition systems, which don't necessarily mean paying people differently, but it means giving them a pat on the back or a thank you note or appreciation in a meeting for purpose-driven work. And so tools, systems, and reinforcement of principles, those are things that all leaders, physician leaders, hospital administrative leaders, like that's sort of our responsibility to those on sort of the front lines of healthcare delivery and driving value.
And you mentioned data, and also that you've been at this for a decade at University of Utah Health. How have you been able to measure improved value?
That's another great question, and I'm sort of chuckling in my mind because it's been a little bit of a journey. And I think the first thing when I think about data and measures, the first thing that I always think about and tell people is that data and metrics are nothing more than a tool. And they're a tool to help us learn and gain insights about the care we're delivering, and a tool that helps support and enable improvement. They're not a result in of themselves. And that's important because all data, all metrics are imperfect. And one of the things we're really good about in healthcare, and in particular my physician colleagues, is not wanting to act until I have perfect data, which will never happen. Basically, that's an excuse to never want to act or change. And so it's the first thing is saying there's no one-size-fits-all solution. Every hospital, every clinic, every system has good enough data assets to help promote learning and improvement. So that's the first thing. Like, there is no magic bullet, and we've all got those assets. It's how we deploy them that is important. But for us, I also think that we've learned that there are certain types of data or measurement assets that really help drive transformational change. And one of those is moving beyond some of our typical process measures of care, or, what I call disutility metrics, some of our harm indicators, which are important, but they're only a small part of the puzzle, that we do need to mature to where we're really looking at actual outcomes of our patients. And those can come in two flavors. One is something that we have a little bit more experience with in healthcare, which is clinician-reported outcomes. So things like mortality rates would be an easy example of that. But more and more, many of our hospitals and health systems are using things like clinical outcome registries. So for hospitals that do a lot of cardiac procedures, most of them now participate in a registry by the Society of Thoracic Surgery. That's sort of the gold standard in clinician-reported outcomes. But we also believe, I also believe that the future is really sort of moving down a path of collecting patient-reported outcomes. Really, and the way I think about those is quality of life indicators, because ultimately we can think we did everything right, but if in the patient's eyes we actually didn't help them live a better life, then we have to ask whether we really did the right thing in those settings. So outcomes is one. The second is cost. That we do spend 18% of the GDP on healthcare, and if we are not incorporating some measures of cost, then we're really not focused on learning at how to drive value. And cost is one that can be complicated, but it can also be relatively simple. We've invested a lot of resources in having a cost accounting system at the individual patient level to drive change, but others who may not have the types of data assets we have could do things like time-driven activity-based costing, could look at things like simple utilization rates around how often certain resources are used. So each system is going to be a little bit different, but some measure of cost and resource utilization has to be part of the metric bundle. Mm-hmm. And then the last one is really things that are even more up close and personal to patients. And that can come in things that most of us are doing, like patient experience surveys, and that's important and helpful. But the other one is starting to think about how we're measuring time. I mentioned that for too many patients, the time that they have to think about and spend and invest in receiving health care is dominant, right? Too many appointments, too many patient questionnaires, too much time away from work. And so starting to think about how to measure time and use that as another way to be more respectful of what we're asking patients to do and designing our systems in a much more patient-centered way. So that's a long-winded answer, but hopefully it gives everyone the sense that there's not one right or wrong set of metrics, but there are domains that we all need to be thinking about, and that value is multidimensional. So we need to be thinking about things through several different lenses.
And I also think it's important to note that, it comes from all of these different places, and it is a journey. What you're measuring today can change next year if you find new ways to measure that may be better or may tell a better story around patient experience. So I think that was an important point that I took from what you shared as well. And you talked a lot about patient experience and really understanding the outcomes that matter to patients and how to measure what is mattering to them. You've done a lot at University of Utah Health around gathering data and input about what value means to different stakeholders. And I remember you sharing at our executive forum a statistic that 72% of clinicians say it would be worth it if they had more time with patients. So they would have more time, they'd have fewer patients, and they were okay with that, even if it meant they would have a reduction in revenue and income. Why do you think that is? And how can providers build those relationships with patients to really understand what they want their outcomes to be and how they can improve their patient experience?
Yeah, it was an interesting insight, and I always sort of smile because I say that although many of my physician colleagues may say that they take a reduction in their paycheck to have more time, the enthusiasm with which it would be met if I said, "Oh, great, well let's reduce your salary by 20%, and then we'll give you 20% more time," I think would probably be met with a lot more skepticism. But it was an interesting, in fact, fascinating insight. And I think it's a reflection of how difficult our current care environment is for our providers, and how many of our providers, not just physicians or advanced practice clinicians, but I think the same holds true for our nurses and pharmacists and others, that there is a feeling that we don't have enough time to be as present with our patients as we want to be. We have more and more documentation requirements, and we have the introduction of electronic health records, and we have more technology and more teams and more specialization and more complexity that leads to this feeling of being more disconnected from, those tender caring moments with which we, many people went into healthcare to sort of have as a core part of what we do. So I think that there is some reality there, and I also think it's a signal that helps explain, some of the burnout that we see in healthcare, that there's this moral injury of not having the time to be present as we want. But the good thing is there's a lot we can do about that. Mm-hmm. And the things that I think about, one is that it starts with listening. By slowing down, listening to our colleagues, listening to our patients. Listening helps make sure that the time we're spending is having the greatest impact. The other is that we have this, especially our physicians, this intense sort of individualism where we think that everything rests solely on our shoulders, which is not the reality, right? We work in an environment that is dependent on teams. And so the other thing that we can do to build time and to reconnect with patients is learning how to more effectively lead and empower the teams around us. That in itself will lead to better outcomes and also free up time. And then lastly, to me, there is a little bit of advocacy. We sometimes are our own worst enemies, where we recognize we need more time. But boy, if we work in a system that, has financial incentives for even more productivity, more work RVU generation, that sometimes we don't advocate for ourselves enough and say, you know what? Actually, that type of incentive isn't important to me. What's important to me is to be paid fairly and to have the time for my patients. So there is an advocacy part that I think is also important.
You mentioned teamwork and empowering collaboration. What are some of the things that you've done at University of Utah Health to really improve teamwork and improve the value of the care to patients?
Yeah, I think, teamwork is something that we have continued to evolve in our thinking as well. And if you think about the historical framework that we think about teams, we sort of think about things like sports teams, right? Where you have people that come to practice every day. And so you've got, lots of time to build trust and to learn how to effectively communicate with each other and to improve our team's performance. But again, that paradigm is also disconnected from the reality where we oftentimes we don't have that stable team. As an example, as a hospitalist, when I'm on service, boy, the team around me taking care of an individual patient in an individual moment at a time is completely fluid. One patient has one nurse, another patient has a different nurse. Later in the shift, the nurses might have changed shifts, and so there's a different nurse or a different pharmacist. And so for us, I think we have tried to promote, rather than teamwork, the things that are necessary for teaming to happen. And teaming is a little bit harder because you've got to build trust and learn how to effectively communicate and learn how to do better sort of on the fly. And through that lens, I think for us, it's important that leaders do a couple of things. One is to be really clear up front that when we're teaming, we're not always going to get it exactly right the first time. And so there's a learning process. And so the first is to actually state that, frame it out loud. Hey, we're here to learn together and we may make some mistakes. Our job is to help support each other to not make any big mistakes that can negatively impact the patient. The second part of that is being really intentional about promoting psychological safety, creating an environment where everyone, whether it's a student, a resident, a nurse, a pharmacist, social worker, feels completely empowered. And in fact, it becomes a cultural expectation that you speak up, that you throw out your ideas of what's needed for a given patient, to stop the line if you see something that doesn't seem right. Mm-hmm. And that psychological safety is sort of counter to sort of the historic culture in healthcare where, there's a little bit of a hierarchical, fear-based environment with sort of, the authoritative physician at the top. And so we've really tried to flatten those hierarchies and to break down those silos and to create an environment where it's safe for people to speak up. Because once we do that, then learning happens. And effective collaboration and effective teamwork really is about learning. And I think those are some of the elements that we found to be really critical on driving success in that area.
I guess I'll just end with one last question, because this conversation has been really great, and I think it's really brought out the importance of value and building the right space and culture to promote value at every level of an organization. But when we talk about this culture of value, if you could give a call to action for providers and leaders in the healthcare space as they take it on, what would it be?
Yeah, I think it's pretty simple in my mind, and that is it starts with me. The first thing for all of us, and I think we all have a tendency to do, is to sort of want to wait for someone else to take the lead, wait for the perfect data to be present, wait for alternative payment models to come to fruition. But the call to action is we must do better for our patients, and that has to start today. And that starts with taking the first step. It starts with driving the conversations around how clear we are as individuals and those around us with our purpose. Are we really talking a lot more about purpose than we are about profits? And if we start there, the rest will follow. Mm-hmm. So for me, it is having an honest moment with ourselves and taking the first step.
Bob, thank you so much for being with us today, and thank you for always being a positive leader in our healthcare field and a contributor to the Value Initiative. I know I've learned a lot from our conversations and the education that you've provided, not only at our executive forum, but at other AHA events, and I am always appreciative of your time, and thank you again for being with us today.
My pleasure. Thank you, Priya.